Hello, this is Dr. Margaret Elizondo, and I'm happy to share with you today my presentation on medical aid in dying around the world. I've been a hospice physician since 2011 and was in family medicine for nearly 2 decades prior to that. I've been with Sharp Healthcare for my entire career, and my medical practice included hospital work, where I saw too many deaths happening without an opportunity for closure and without people having talked about the fact that death was imminent. Our society tends to deny mortality and feels that talking about end-of-life issues may make people depressed or give up hope. But for me, end-of-life care has not been depressing. It's actually been hopeful and gives people a chance for a good death. In this talk today, we have a number of objectives to accomplish. I will go over the options for assisted dying in various areas and especially review the countries we're going to be visiting on this particular trip. Assisted dying means allowing a lethal dose of medication to be given to end a life of intractable suffering. And in the past, people have used words like euthanasia or suicide for this, but we have better words to use, and we'll define the language that's been used in the past and perhaps some better ways to characterize this option that people often choose. Nurses, as part of the medical team, may be asked to participate in this process, and we'll go over when that might occur. And qualifiers for this option vary from country to country. Patients don't always have to be terminally ill in countries outside the United States. But for the U.S. and in California in particular, we will review at the end the procedures and medications that are used, and that is pretty much a uniform process for all of the United States in terms of qualifications. So what is assisted dying? As we said, euthanasia and suicide are probably not the best words to use. Euthanasia is really done to someone, not for someone. Suicide is often associated with hopelessness. And whether or not these situations are always physician-assisted, certainly there is legal paperwork to go through, and the physician is required to prescribe medication. Physicians in the United States are not allowed to directly assist someone in actually ingesting medications for end-of-life care. So when we talk about medical aid in dying, it is the voluntary use of medications by patients to choose their time of death instead of having to face intractable suffering associated with a variety of illnesses. It is highly regulated in all countries in which it's permissible, and it varies considerably in its use and acceptance around the world. Some countries have decriminalized suicide and or assistance for people who want to, quote, commit suicide by taking a lethal dose of medication. And not all of those countries have yet legalized the process outright. Examples are Germany and Italy, and Germany, as one of the countries we're going to be visiting, doesn't have exactly assisted dying laws yet, although they are still discussing them, but they have decriminalized someone's assistance in helping others take a lethal dose of medicine if they are, chronically ill or have intractable suffering. We are visiting Switzerland, that has the most experience with assisted dying back to the 1940s. And we're also visiting Austria, which just passed legislation in 2021, so is one of the newest countries to allow this. And we'll compare and contrast what the requirements are to use this option. So again, going over the loaded language I alluded to before, euthanasia actually has its roots in ancient Greek and means good death. But historically, we've tended to use this term only for animals and criminals. You know, some states in the United States allow lethal injections. There are also some people who try to temper the word euthanasia by saying passive euthanasia would be withdrawing life-prolonging treatments like ventilators, feeding tubes, kidney dialysis, and active euthanasia might be giving excessive, comfort medicine to someone, like an overdose of morphine or Ativan or some combination of both, to actually try to cause death. And that's generally illegal unless you have met specific requirements, which depend on the country you're in terms of being allowed to use assisted dying. Now, suicide is a active term in terms of wanting to end one's own life. Historically, it's been considered immoral and or illegal. Passive suicide, again, might be related to refusing or withdrawing life-prolonging treatments. Again, these are treatments that weren't even available a century ago, and whether people should be forced to use them now just because they're available doesn't seem ethically right. It seems that people should be able to decide what they want or don't want from our modern medical system, but some people are very passionate about using everything possible to keep someone alive. So it gets touchy for many people. Now, assisted suicide, which used to be a common term used with assisted dying procedures. Physician-assisted suicide was a common term used decades ago. Means that you're giving somebody else the means to end their lives. Now that could be something like a gun in addition to a lethal dose of medication. And assisting someone in suicide still is problematic in many states in the United States and in many countries around the world. With modern legislation and people demanding autonomy about controlling their own bodies, especially when they are subjected to chronic suffering or from chronic diseases or terminal illness especially, other words have been used like death with dignity. That's what was used in Oregon, which was the first of our states in the U.S. to allow assisted dying. Medical aid in dying is the term used in Canada, and they are recent comers to this option for ending life at the time that you would like. And then assisted dying is sort of the word used most around the world in terms of what we previously would call assisted suicide. So why would people choose assisted dying? In many cases, it's because of intractable suffering. That may or may not have to do with terminal illness. It could also just be chronic illness. We don't have a cure for every disease out there, and we don't even have all the medicines that people need to stay comfortable as they cope with chronic illness. In the United States, people must be terminally ill to avail themselves of any assisted dying options. But in other countries, they don't necessarily have to be terminally ill. People generally abhor the idea of a lingering death. Most commonly in the U.S., we will see this with neurodegenerative diseases and chronic mental illnesses such as dementia. And people are worried, especially with illnesses that are neurologic and in nature and involve mental health. They're worried about losing their sense of self as they have ongoing cognitive declines and have less and less control over their lives. Some people worry about disfigurement of certain chronic illnesses. I remember a patient who had a very disfiguring head and neck cancer that was eating away at her nose and her eye. Was very painful, but she chose to just put up with that and let it take its course. And it took about 2 years on hospice services for her to finally go, quote, naturally, unquote. But this is one of the places where many people would be happy to avail themselves of assisted dying options so that they wouldn't have to suffer for months or years from something that was going to take their lives anyway. The cognitive declines that people see with dementia are disturbing to patients as well as their families and caregivers. The physical decline is intertwined often with cognitive decline. People with chronic illnesses, and especially terminally ill people, can have delirium. They get infections more easily. The infections can also cause delirium, and and when people get delirium, they have a physical decline in their functional status as well, so it just snowballs for people. And eventually people just are not so interested in living anymore in that circumstance. So the people who typically choose assisted dying are not those who others are worried we might have a slippery slope, that we're going to take advantage of the poor or the disabled and encourage them to choose assisted dying if they're chronically ill or terminally ill. People have to advocate for this for themselves, especially to get it in the United States. But almost all the countries make it mandatory that people are acting voluntarily and have capacity at the time that they're making this decision, so that they show that they understand what they're choosing. And in the United States, our experience shows that people are usually highly educated, and they value their autonomy. They are usually experiencing intractable suffering, and usually already are having concurrent palliative care or hospice, and yet are not comfortable despite all of the medical treatments that are available these days. Even countries that have had laws for decades allowing people to use assisted dying see very few people choose this option. It's a tiny minority of people who would choose assisted dying versus just ongoing palliative care or hospice care. And payment for it is problematic, or maybe not, depending on your stance on how available this should be to people. Most people have to pay for it themselves entirely, and that would include the medical consultations as well as the medication itself. In the past, we just used a high dose of a barbiturate called Seconal. It was a popular sleeping medicine back in the 1950s or so. In a dose of 100 milligram tablets, if you take 30 of those, it's considered a lethal dose. Most people would just prescribe a standard bottle of 100. You'd be getting 3 times the lethal dose, and people would open up those capsules and take all the powder and mix it with liquid and take that, and most people would be unconscious within minutes and stop breathing within an hour or so. It used to only cost about $300 for that whole bottle of medication, but it's not used very often in the US, and at one point became available only in Canada, and then started being used only for the assisted dying option. So the price of it skyrocketed from $300 to about $3,000, and then because of, I think, partly concerns about bad press about just manufacturing this drug for people to be able to give themselves a lethal dose, they stopped manufacturing it altogether. Switzerland uses pentobarbital, which you can't get readily in the United States at lethal doses, and we really don't have other barbiturates still available in the US that you can get at high enough doses to make sure that somebody is going to be successful in their assisted dying process. Medi-Cal, which is California's Medicaid program for the poor, actually will cover the cost of the medication. Generally, no other insurances will cover it. Medicare won't cover it, and private insurances won't cover it at this point. And it can be thousands of dollars potentially to cover the cost of the medical consultations that are required, the paperwork that needs to be filed, and the medication to be given. The other thing I wanted to review was the terminally ill versus chronically ill issue. In the US, in all of the 10 states and District of Columbia where assisted dying is allowed, you have to be terminally ill. And that means that like with hospice, 2 physicians need to be willing to document that they think that there's a better than average chance that you will be gone in 6 months or less as this disease process proceeds. In other countries, you do not have to be terminally ill, and you don't even have to have a chronic physical diagnosis. You can have a mental health issue chronically, potentially, including dementia in other countries, but you still need to be at the point in your disease process where you can verbalize or otherwise express your understanding of what you're requesting and that you're acting voluntarily. So you have to have capacity to request this. The issue of chronic suffering is really the key. In Switzerland, they don't consider suicide a criminal act, and they don't even worry about assisted suicide if you help someone else to take their own lives if there's no, quote, selfish motives involved. Most people around the world who use assisted dying are terminally ill. And of the small minority who are not, very few of them have a chronic mental illness alone. And again, people have concerns about the slippery slope, that if you allow this for too many people, there's then going to be pressure that anybody who is a burden to society in any way is going to be encouraged to pursue this course. But again, even in countries that have allowed assisted dying for chronic illness, including mental illness, without being terminally ill, even countries who have allowed this for many years now, have not seen a huge number of people avail themselves of this option. In Europe, it's about 2 to 4% of all deaths are these assisted dying deaths. And when it comes to mental illness, it's even far fewer of those deaths. So again, the concerns about a slippery slope seem unfounded with the history we've seen so far. Now, people are worried about, depression and taking your own life. Clearly, depression is associated with hopelessness that leads to active suicide. We don't want people who are depressed and could be treated potentially with medication or therapy or both to use assisted dying without careful consideration. And chronic physical illnesses can also be associated with depression. That is understood. But there is a difference in terms of the hopelessness that is associated with wanting to commit suicide or take your life that way due to depression alone, versus a hopefulness that people have when they're using their autonomy to say that they want to pursue this option. People will say, if I'm going to die anyway, I want to be able to choose when and how that is going to be. Not everyone has religious convictions that their deaths are in someone else's hands. They want to have control over that part of their lives as well. So wanting to end suffering of chronic illness is not necessarily due to a hopelessness as in depression, and that's really important for us to focus on. The use of medical aid in dying is associated with hope and autonomy in using your option to choose when you die, rather than having to go through suffering that's going to lead to your death in any case in the relatively near future. Support of surviving family members and caregivers and the medical team members as well is really important. And so we do want to make sure that anybody who chooses to be involved in this gets the support they need. That's why we always encourage people to have concomitant hospice care when going through this process, because if you have hospice care, your survivors get bereavement counseling for free for up to 13 months following your death. That's just part of the process and the benefits. So this next chart here is a little busy, and it's got a lot packed into it, but believe it or not, it's the simplest one I could find that sort of gave us a good overview of comparing what is available in different countries around the world. And so I want to review it a little bit so that we know how different things can be outside of the United States. So this chart, the columns are separated into whether you have to self-administer medication or whether someone can assist you to do that. So that's the first two columns that say self-administer only or self or active assistance. And then the next three columns talk about terminal conditions versus severe chronic physical conditions or severe chronic mental conditions. So every place allows terminal conditions. So you'll see there's a check box in that third column all the way down. What's most notable are the ones that require you to have a terminal condition versus just a chronic physical or mental condition that's giving you intractable suffering. And then the last couple of columns before the column with the years is some more rare options that people have in certain countries, and that is to use an advance directive to write down in advance whether you would want to avail yourself of an assisted dying option if in the future you developed a chronic medical or chronic physical or mental illness, dementia specifically in that case, and that's something that's not available in many countries. Now, if we look at the rows top to bottom, you'll see that there's a separation of Europe versus the Americas versus Australasia, and this is not separated based on the oldest to newest years in which people had the assisted dying option available in some way legislatively in their countries. But you can see off to the right, there are years that different countries have implemented some sort of legislation that allows for assisted dying. And the newer ones are near the bottom, including us in the United States and Australia and New Zealand at the very bottom. So Switzerland is the one that's been doing this the most often since 1942. And then the US did get in the game relatively early compared to other places in Europe, with Oregon passing its death with dignity laws back in 1997. Then it took quite a while until Washington State joined in 2009. And then there have been a ton of states since 2002, but most just since 2015. And same thing for various countries around the world. More have gotten on board since the year 2000, but especially more have gotten on board just in the past few years. So we'll go over some of the specifics in the next slide. So some of the notable outliers are only a few countries require that people have to self-administer the medications, and nobody else can help them with that. So all of the United States, all of the states that allow this, as well as Switzerland, even though they've been doing this the longest, they still require everybody to self-administer medicines. And then one of the countries that's joined most recently, Austria, requires people to self-administer. That means that you're taking something, you're ingesting something, and almost always things are taken either orally or by a feeding tube or rectally. These are not lethal injections. That's a rare option in most places. But most countries do allow people to assist in one way or another. In the US, we can assist with preparing the medicine, but when it comes down to actually ingesting it, even if someone can't hold a cup, they need to at least be able to sip from a straw and take it themselves in that way. That's what they mean by self-administration. And next notable outlier is who allows still only terminal conditions. The United States, again, as we said before, you have to be terminally ill, and some of the newer countries into this process, Australia and New Zealand, also require that people be terminally ill. There's no option for chronic illness only, as there is in most other countries around the world. And then that last part that I talked about in the last slide about an advance directive being allowed, this is a huge thing, to be able to determine in advance what you want to do, because in most cases people require that you have capacity at the time that you make this decision to be able to say you want this done, you understand the risks, benefits, alternatives, you are acting voluntarily. But some countries, including Austria, which is new to the game, but they are allowing people to use an advance directive for chronic physical illnesses. Belgium, which has been doing this a lot longer, they allow advance directives. And then the Netherlands, they also are probably the most lenient country in terms of what they allow people to do. They even allow dementia to be something that you can write, that if you have that in advance, you would want the option for assisted dying. So again, not all require that you be able to self-administer, and that's very helpful if you're someone who has ALS and can't, do anything for yourself in that regard. Not all require a terminal illness. Some allow advance directives. And then there's Switzerland that we're visiting. Switzerland is the only one that allows non-citizens to use assisted dying. And we'll discuss that a little bit sooner. In terms of self-administration, Belgium is one of the countries where you can actually have somebody else give you a lethal injection. But again, all these countries we're talking about, currently you have to be a citizen or permanent resident of that country to avail yourself of any of their laws, except Switzerland. Switzerland is one where you can come from another country, and certain organizations will allow you to use assisted dying there. So it would be one way for people to use assisted dying even if they were not terminally ill. So for medication administration, when we talk about assistance in taking the medicines, in all of the US states, you have to be able to give this to yourself. But if you can't swallow anymore and you have a feeding tube and you're able to use a syringe to put this liquid, which generally has to be at least 4 ounces, so we're talking about 120 mLs, that would be 260 ml syringes. If you have the ability to do that, that is one way you could self-administer in the US. And then more and more people are using rectal tubes. You've probably heard of the Macy catheters people are using to administer medications when they can no longer swallow safely in hospice care. People are using these catheters because that, venous plexus inside the rectum absorbs medications very well, much better than our buccal mucosa in the mouth. And so when you use a catheter and administer medications into the rectum, they are absorbed very, very quickly, quicker than the stomach actually. So that's another way that people can do self-administration. Again, they would have to be able to physically use their hands in order to manipulate a syringe in order to actually inject the medication in there, but you are allowed to have somebody else help with the preparation of the medication in terms of mixing fluid with the powders of the various pills before the actual administration. So some people are not going to be comfortable helping their loved ones doing this, and some people on medical teams are not going to be comfortable doing this. There is still that euthanasia stigma if medication is administered to someone by another person and it's for the purpose of making them stop breathe. And then, of course, there's the suicide stigma that people have about administering it themselves, or that stigma that family members will have if somebody they love is choosing this option. So we have to try to support people the best we can when they're making these decisions for themselves and using their autonomy to do that. Now, the history in Switzerland, I wanted to go over in particular since this is one of the places we're visiting. And again, they have many decades of experience allowing assisted dying. There are two organizations, Dignitas and Pegasus, that allow foreign citizens to travel to Switzerland to use assisted dying. Most of the people who come from other countries are either from Germany, about 60% of people that go to Switzerland, and the UK, about 30%. And so there's another 10% who come from various other countries, including the United States. The cost is somewhere around $10,000 for most people when you factor in the cost of traveling there, and people have to stay there for a few days before the actual procedure. There is a lot of paperwork that Switzerland will make people go through. And they do want to make sure that people are acting voluntarily. They have capacity to make this decision, so that if you're doing this because you have dementia, let's say, you can't be so far along that you've lost your capacity in dementia. But in the US, of course, if you have gotten far enough along in dementia that it is your terminal illness that qualifies you for hospice, generally you no longer have the capacity to avail yourself of this option. There is a great book I read called In Love by Amy Bloom. It is a nonfiction work of her experience taking her husband with relatively early dementia to Switzerland to use the assisted dying services of Dignitas. And she is very good at going over all of the issues with dementia, all of the pros and cons of trying to, treat dementia, which we don't have a lot of options these days, what it's like to watch someone die of dementia, alternatives to assisted dying with lethal medication. She goes over, the voluntarily stopping eating and drinking, that's VSED. That is an option for people, but it's kind of hard to stick to for many. There is the putting the plastic bag over your head and various other options people have that have various degrees of gruesomeness to them, but it's really informative in terms of what people's options are outside of the United States, and I'd encourage you to read that. You'll see it in the end of the talk under my references. Again, In Love by Amy Bloom. It's a wonderful read. So to get back to the US, because I want to summarize by going over what we're allowed to do in the United States, this lists all of the states and the District of Columbia where you can avail yourself of assisted dying. It's called various things in various states. In California, it's called the End of Life Option Act. It was originally passed in 2015, and then there were some, legal issues regarding people wanting to rescind it in years following that, but it is legal currently. The law was upheld, and it is available, which is not necessarily known by many people in our state, which is unfortunate because a lot of people would like to avail themselves of this. So again, before people are concerned about a slippery slope, and there are more and more states that allow this to happen, even though we have had this available for many years in many states, we still see far fewer people using this than even in Europe. It's less than 1% of our deaths in the United States. Of course, only 11 of our states allow it thus far, so we would expect that there would be fewer people using it because you do have to establish your residence in that state, and we have a small minority of people who are able to use it. But when you get publicity like in California, we had Brittany Maynard, who was a young woman with glioblastoma who traveled to Oregon in order to avail herself of their Death with Dignity Act, that really garnered support for the law passing in California, because it had failed to have enough voters vote for it right before she did that, and it was brought up again right after her death, and people supported the law because they saw how important it was for some people who really wanted to avoid a horrible death or a lot of suffering. So in the US, again, I'm going to go over our California End of Life Option Act law specifically. You have to be terminally ill, so 2 physicians must certify that you are terminally ill. If you're on hospice, you know that you already have met that requirement. There used to be a wait period between your first and second request to your attending physician of 15 days. The law requires that you have to put in 2 verbal requests with a wait period in between. You have to have a written request that is witnessed by 2 people who are not family members or not people who would inherit your estate. And the wait period between those 2 requests is now only 48 hours. And then at some point during that period, you also get a consultation from a second physician that documents that, yes, you are terminally ill, you are acting voluntarily, you have capacity, which really means that you understand the risks, benefits, and alternatives to what you're choosing. And the alternatives always include, hospice care to give you the comfort that you need until your terminal illness takes you in its own time frame. Now, in terms of no mental health issues influencing your decision, this doesn't mean that you can't have ever had depression or can't even have depression currently and be on antidepressants. What it means is that if you have depression now and you're on antidepressants, or you've had depression in the past, that depression is not what is primarily influencing you to choose this option. You are not choosing this out of a sense of hopelessness. You are choosing this out of a sense of hopefulness that you can have control over your time of death. Now, people may express that it is hopeless, and that may be the case in terms of how we express that if you have a terminal illness for which there is no good treatment, it is going to take you, it's just a matter of time, then you could say that this is a hopeless situation in terms of medical cure or treatment. But that doesn't necessarily mean that mentally you feel you have no hope for how your death is going to look. So it is a fine line to try to tease that out. If anyone has any concerns as an attending physician or consulting physician about whether someone is acting appropriately, they can always refer the patient to have a third assessment by a licensed psychologist or a psychiatrist in order to make sure that mental illness is not the primary driver for the patient seeking this request. So when people have gone through all of this process, and you can see it's a lot of paperwork and it's a lot of thought people have put into it in general, the medical team may ask to be involved, and this is where nurses may ask to be involved. Over 95% of people who use the End of Life Option Act in California also have concurrent hospice or palliative care involved. So they have alternatives to make sure that they've got good symptom management in place, and they're not making these decisions just based on desperation because they're so uncomfortable. And Hospice care, especially, is a multidisciplinary team. It's a minimum of a physician, nurse, social worker, and spiritual care counselor. Our hospice services also involve home health aides, volunteers, music therapy, and some team members may be asked by the patient or family to be present at the time of the administration of the End-of-Life Option Act medication. Obviously, there's no requirement for that, and at Sharp Hospice, if we know that a patient is interested in the End-of-Life Option Act, we make sure that all the team members are comfortable with remaining on the team, taking care of this patient before they get too far down the line with requesting medications and having lethal doses of medications in the house. As I said before, others, which can be medical team members or caregivers or family members, can help in the preparation of medications up to the point of administration. So more and more the medications we're using already come in a bulk powder form to make it easier for people to mix this with fluid and ingest it. In the past, we used to have to open up capsules or crush pills, and that was a lot of work for people to do. But whatever is required now, again, you can have somebody else mix up the medication for you with fluid. You can have them bring the cup close to you as long as you're able to drink that with a straw. Or you're able to take the glass and ingest that into your mouth, or use syringes to inject this into a feeding tube or to a rectal tube. Again, other people can help up until that point. So often, depending on the patient and how close they have developed a bond with their hospice team members, some people may request that often their nurse or social worker or spiritual care counselor be present at the time that they take the medication. And that's an option and something people should be prepared for. And at Sharp Hospice Care, we have a whole separate advanced care planning team that has dual goals of making sure people are prepared in advance with their advance directives, and they also are the people who help patients navigate the End-of-Life Option Act if they are interested in that. So sometimes some of the people who are interested in End-of-Life Option Act can ask one of the advanced care planning team members to be with them at the time of ingestion. And again, these medications require at least 4 ounces of fluid to be mixed with them, and they generally want to take that in a short period of time, so people have to make sure that they still have the capability of doing that. And people can stop along this process anytime they want, even if they go so far to get the medications in their house and then choose a day and a time to do this and bring all their family members there and then decide at the last minute they don't want to do it. That's not a problem. They can stop at any time, and this is where it's so important for us to remind people that this is voluntary, and that they never have to go through with things, even if they've gone 99% of the way. So in terms of the actual medications used these days, most people are given both Regland and Zofran together in fairly high dose as antiemetics about 1 hour prior to ingestion of the medications. We prefer that people have an empty stomach because they're going to absorb the medications that much quicker and hopefully make the process go very smoothly and not be a prolonged issue. It is okay to mix the medications with some palatable liquid. Some of the medications are quite bitter. and it's okay to put it in some juice that is sweet, something that people like, because we really would like the medication to be ingested within a couple of minutes, and that's a minimum of 4 ounces to liquefy all of that powder of the medications. And so we want to make sure people feel comfortable that they can get that all in within 2 minutes. And that's a bigger deal if you're using syringes to put medication in through a feeding tube or a rectal tube. So again, you would probably want to draw up the medicine in 260 ml syringes ahead of time, have that ready, and then the patient has to be able to use the plunger and inject that medication into those tubes themselves. And what we use these days, since we no longer have the Seconal option, is we tend to use a combination of cardiac medicines and sedatives. So a very high dose of digoxin, often with either propranolol or amitriptyline, which will lead to cardiac arrhythmia, combined with morphine or some other narcotic, and diazepam or some other benzodiazepine as sedatives, is what is used. Again, we talked about the different routes people can use for self-administration, and most people are unconscious within 15 minutes of ingesting this, and their breathing usually stops within an hour. In terms of advising patients on what the complications could potentially be, occasionally we have seen people have seizures. My guess is this is related to the arrhythmia that is created on purpose, and then the subsequent hypoxia that goes with that. So we have seen one patient have seizures, and that was uncomfortable for the caregivers and family to witness. People are given a high dose of diazepam in advance, so most people won't have seizures. They're given a high dose of morphine in advance so that there should not be any pain involved with this. But of course, most of these people are already on hospice care, so some of them already are taking narcotics and benzodiazepines and may have a fairly high tolerance to them. So it is possible that they will need extra medications. Occasionally people are given some more medication through a oral concentrate that you can put under the tongue or in the cheek. Most of those medicines, except for something like methadone, still has to trickle down into the stomach in order to really be properly absorbed. But again, if there's a need for extra medicines after the End-of-Life Option Act cocktail has been given, that can happen if people are able to still tolerate having something in their mouth. And in that case, we're giving this for comfort based on symptom management. We're not assisting them directly by giving them medications with the hope of stopping their breathing. There is a double effect issue there. If our goal is that they look uncomfortable after taking the End-of-Life Option Act medicines, and they look like they're having pain or they're having a seizure, and there is a possibility of giving them medication to stop those symptoms, we are allowed to assist with that. And again, in most cases, it's not an issue because people are usually unconscious within 15 minutes and their breathing stops within an hour. There are some people who will hang on for many hours after. It might be 12, 24 hours to some. They just seem to be in a very, very deep sleep, and they develop more apnea and eventually will stop breathing. So after something like this has happened, and people have had a successful death from End-of-Life Option Act, there's no need for people to put on the death certificate that they, utilized lethal medicine to take their own lives. We put on the death certificate that they died of whatever their terminal illness was. So this is not considered suicide in California if you're following the right procedures. Paperwork is filed with the state of California by the attending physician, and it includes the physician and consultant certifying that people are terminally ill, acting voluntarily, have capacity to do that. There used to be a need for one other piece of paper, which was a 48-hour intention to use medication paper for the state of California. And they wanted people to file this, send it into the state within 48 hours of actually using the End-of-Life Option Act medications. I'm not sure exactly what they thought the benefit would be of using that, but as you can imagine, once people get the End-of-Life Option Act medications into their house, it is then their medicine. They can do what they want with it. And most people didn't end up turning in this last piece of paper on their own, and they have now done away with that requirement. So 2 changes since the law was first enacted several years ago is that there's now only that 48-hour wait between first and second verbal request to your attending physician, and there's no longer this 48-hour, intention to use medication paperwork for people to fill out. And again, really advocating for hospice care. Anybody who's been on hospice for even one day gets bereavement services free of charge for their surviving family members for 13 months after death. And that is incredibly helpful and reassuring for survivors. So we encourage people to make sure that follow-up includes allowing people to process what they've been through with this sort of death, which may be harder for some than a, quote, regular death with hospice care.